My name is Adriana Green. I'm a fourth year medical student. This project is titled Introducing Adverse Childhood Experiences to Third Year Medical Students. So, adverse childhood experiences, or ACEs, are various forms of physical and emotional abuse, neglect, and household dysfunction that can be experienced in childhood. And these have been linked to negative mental and physical health outcomes, such as cardiovascular disease, diabetes, liver dysfunction, and even cancer. So the knowledge and practice of these ACEs has slowly been gaining traction in mainstream medical practice to prevent, recognize, and address these adverse experiences that can affect the patient's health. And then we see this as what we see below in the middle bottom portion, these adverse childhood experiences surveys that can be administered to patients to ask about these experiences. And then also looking at a resiliency survey to assess some protective factors in the form of resilience that can mitigate against these ACEs. Talking about this with patients is a really good way to have a good holistic understanding of the patients, things affecting their health and the risk factors that they have. But the only area where we haven't seen as much emphasis placed on this is introducing the idea into medical student education. We believe that in educating medical students on ACEs will provide a strong foundation to better understand their patients and the impact of trauma on their patients' health and well-being. And this will also ensure that the acknowledgement of ACEs becomes a regular part of future medical practice and culture. So we wanted to do this by assessing the knowledge and attitudes of students using two surveys that were both surrounded by an educational session. So we held a 1 hour educational session for UAB medical students on the Tuscaloosa campus. This provided knowledge on integrating ACEs into their patient encounters via using a PowerPoint presentation that was then followed by a case-based learning experience where they were exposed to a patient whose ACEs serve as a barrier to their optimum health outcomes. We also introduced resiliency as an intervention for these ACEs. And once again, they use the adverse childhood experiences survey and also resilience survey to compare to the example patient that was used in the case session and filled it out as if they were the patient themselves. So 36 students were invited to participate in this session during their regular weekly relate sessions. 18 students, 50% male, filled out the pre-intervention survey, and 4 students, also 50% male, filled out the post-intervention survey. So some limitations that we had with this is just the number of pre versus post intervention responses that were received. We had a good participation in responses for our pre-intervention as this was asked to be filled out while the patient, before these students started the session while they were there in person with us. With the post-intervention surveys, we asked them to fill this out within the week following the session. So many of the students were not there present with us when it was asked for them to fill this out. We believe this is most likely the limiting kind of factor that contributed to these low post-session responses, and that does limit a little bit of the accuracy of the statistical analysis. But essentially what we did see and learn is that utilizing a 1 hour case-based educational session is very feasible to provide information on introducing ACEs into clinical care. Also, what we looked at is how to foster engagement so that students are best able to learn and then also have a change in attitude surrounding their ideal of ACEs. And we see this with the evaluation here at the top, just looking at the means of responses given on the pre and post intervention surveys. So these survey responses, they were able to be graded on a Likert scale. So the participants were able to rank 1 to 5, 1 being completely disagree, 3 being neither agree nor disagree, and 5 being completely agree. And so we see these with the means and then also the standard deviation with the pre and post intervention surveys. We did notice a shift at least in the responses, more in the positive direction, and their confidence in their ability to screen, as they, and also where they felt like they, as medical students, had the role to screen, and then also just the time and allotment they feel like they have in a clinical setting. So overall, while we did have low post-session responses that did affect the accuracy of our statistical analysis, we did find that utilizing this method of education is feasible to provide information on ACEs and provide it into further medical care. Thank you for listening, and please let me know if you have any questions.